Good morning and a very warm welcome to all of you. I thank you all for joining us today. A very special thank you to our dignitaries, including Honorable Minister of State, Ministry of Health and Family Welfare, secretaries from Ministry of Housing and Urban Affairs, and Ministry of Health and Family Welfare, along with the Honorable Principal Secretaries, mission directors from states who have joined us today. Without further ado, I would like to invite Ms. L.S. Changsan, Additional Secretary and Mission Director at NHM, Ministry of Health and Family Welfare, to deliver the inaugural address and set the context for today's discussion. Thank you, ma'am.
A very good morning to everyone. Respected Secretary, Ministry of Housing and Urban Affairs, Government of India, Shri Manoj Joshi sir. Respected Secretary, Ministry of Health and Family Welfare, Shri Shudhans Pant sir. The Mission Director, USAID India, Ms. Veena Reddy. The Executive Director of NHSRC, Dr. Kotwalji, Joint Secretary, Policy and Urban Health, Ministry of Health and Family Welfare, and my colleague Vishal Chauhan, and Dr. Rajni from Head of the BMGF, our development partners, colleagues, principal secretaries, mission directors from National Health Mission from different parts of the country, Ministry of Health and Family Welfare and Ministry of Housing and Urban Affairs officials from center and from states, and all the participants in today's National Urban Health Conclave. I take this opportunity to extend a very warm welcome to our dignitaries, our respected secretaries, Urban Affairs and Health, and Mission Director, USAID, NHSRC, and Honorable MoS, Minister of State, Ministry of Health and Family Welfare, Dr. Madam Bharati Pravin Pawar, who is going to join us very shortly. This is indeed a long-awaited occasion. We've been planning to have the conclave for discussing matters on on urban health. And I do appreciate the time that you have taken to come out here and join us today. The primary objective of today's conclave is to have consultations on the emerging challenges on the health front, particularly in the urban areas. And you all would agree that while universal health coverage has been our aim, and there is a paradigm shift from just management and treatment of illness, we are moving to a state of wellness, and we are moving to a state where prevention is the key. And through primary healthcare, we believe that we will be able to achieve a huge part of our goal for prevention before the and the wellness approach. You would be aware that the National Health Mission originally started as a National Rural Health Mission in 2005, and thereafter a submission called National Urban Health Mission was born, and subsequently these have been merged together into the National Health Mission. We did come up with a framework for management of the National Urban Health Mission, and today we also are expecting that with the changes that have come in over the years, with the different interventions, we will be able to come up with a revised framework. So with this welcome. I again uh, extend a very warm welcome to all of you, and I'm looking forward to a very meaningful deliberation on this in this session. I would just like to take you through a few slides to set the context on what we are discussing. Is the presentation ready? Okay, it's already come there. Acha, from here, this one, yeah. It's not here. Okay. So as I said about the National Urban Health Mission, this was started in the month of May in 2013 as a submission under the overarching National Health Mission. And rural health was the other and the major aspect of the health mission. Under NUHM, we aim to improve the status of the urban population, particularly the socio-economically deprived. We hope to bring about an equitable and accessible healthcare to the people in the urban areas. And in this, the mission envisages an active collaboration with the urban local bodies under the Ministry of Urban Affairs. So far, the NUHM has been implemented in 35 states and UTs across the country. And we have the mission in place in districts and towns with over 50,000 population, and in district and state headquarters above 30,000 population. We have 1,213 cities, including 7 metro cities, which are covered under this mission. And these 1,213 cities and towns cover about 70% of the total urban population of our country. These are either under the municipal corporations or the town committees or notified area committees. You would all agree that the urbanization scenario is rapidly evolving. One, there is a huge trend of migration towards urban areas. Currently, we stand at around 31% of our population being in the urban areas. And according to projections, it might be around 50% by 2050. So therefore, we really need to focus on this area, in the urban areas, and how to reach health coverage in these areas. So far, we've been having 3 models of implementation in the states for the urban health mission. In the first one, there is the health care activities is primarily, it's looked after only by the health department in the state government. The urban local bodies are not involved. Examples are like states of Himachal Pradesh, Bihar, Uttar Pradesh, Punjab, J&K, Jharkhand, Madhya Pradesh, all union territories and Northeast states. In the second model, we see that there is no role of the health department in healthcare in the urban areas. Rather, it is the urban local bodies which look after all aspects of healthcare. So we see these in majorly the big metropolitan cities, and then we see that in the major municipal corporations, some like in the state of Gujarat, in Tamil Nadu, in West Bengal, and in Maharashtra. And in the third model, we have the urban local bodies in a supportive role, and the state health department plays a significant role in managing the health aspects in that state. So we see this model in states like Chhattisgarh, in Kerala, in Odisha. So we have given complete flexibility to the states according to the structure which suits them best. Traditionally, how the healthcare system has evolved in especially the social sectors like healthcare, like education. So there are different structures, and we have given flexibility to the states to evolve. And this depends hugely on the capacity of the urban local bodies as well. Under the mission per se, urban health mission, we have no separate structure. The overall national health mission, the governance structure, takes under its wings the rural as well as the urban healthcare aspect. Although we do have a separate program management unit at the state and district level, and what we call city program management units, which have been created under the local urban local bodies in the 7 metro cities and in other areas where there are big corporations. And at the facility level, what we call the Rogi Kalyan Samiti has been established, and Jan Arogya Samitis, which are at the urban community health center and the urban primary health centers, health and wellness centers, and urban health and wellness centers, respectively. This gives us a brief idea about the kind of population based on which we have categorized the different facilities. These, with a population of over 2.5 lakhs, we have what we call the urban community health centers. From 50,000, 30 to 70,000 population, we have the urban primary healthcare centers. With populations of 15 to 20,000, we have the urban health and wellness centers. I will come more to that. Then you have an A&M for every population with 10,000, and ASHAs for population of 1,000 to 2,500, and covering a household of 200 to 500. We have one Mahila Arogya Samiti, that is for the women's particularly, for 250 to 500 population, covering 50 to 100 households as well. So these are the different service delivery models that we have under the National Urban Health Mission. I have already talked about some of these points, that under the Urban Health Mission, we are covering 1,213 urban areas and 5,195 urban PHCs and 225 urban CHCs have been established. Now, 4,821 urban PHCs have been transformed into the health and wellness centers. And the health and wellness centers are many steps above what we used to call the sub-centers in the health parlance, where under the universal health coverage, we are assuring the 12 services in addition to RCH, non-communicable diseases, meditation, geriatric, ENT, oral care, and several other packages are covered in the health and wellness centers. We have also augmented the health systems, the workforce, the human resources. About 38,000 have been added, which includes doctors and staff nurse and pharmacists, A&Ms, public health managers, and at the state and district and city level. We have also engaged 81,168 ASHAs. I think ASHAs need no introduction here. And 83,888 Mahila Arogya Samitis have been formed. We also have a system of certification of our healthcare facilities, and we have 201 urban PHCs certified at national level, and many of our centers in the urban level have also won the Kaya Kalp Awards, and they have got a very respectable score of over 70%. When we talk about urban health, yes, we have to look at the mapping part and planning for it, and ultimately it comes down to financing. And other than what financing is there under the National Health Mission, under PM Abhim, this is a new scheme, and the 15th Finance Commission, we have a huge outlay. Under PM Abhim, we have 64,180 crore, and under 15th Finance Commission, 70,000 crores. Out of this, 33,931.75 crores are provisioned for urban areas alone. So we have a good, we are in a good, decent position as far as funds are concerned. But today, why we have requested everyone to come together is mainly because we need to work much more on the collaboration part. Because as I said, in the service delivery models, there is perhaps not the kind of clarity or collaboration that this mission, this program urgently needs to see. We feel that there could be a lot of collaboration with urban local bodies as far as orientation and capacity building is concerned. We need, on the other hand, support of the urban local bodies in identifying the locations, in helping the health mission in finding buildings or locations to establish the healthcare facilities. In urban areas, space is always premium, and therefore this becomes a very important area for collaboration. And also not only the improving the existing health facilities in the urban areas, expanding them, but also establishing new health and wellness centers. In urban areas, as I was discussing with my colleague Vishal here, the tendency is to think that the government intervention, there are already a lot of private hospitals and healthcare establishments, and we often tend to think that it is only the poor and the lower economic class that will need the services from our urban healthcare centers. But actually, if we build up the quality, if we improve that and set them up to the IPHs and the well-established healthcare standards, then I'm sure that it will be a boon to even a much larger segment of the urban population, even the middle class and whoever. I mean, because of accessibilities, if it is located near their areas, then and with good service delivery, this could well become a very efficient and effective pattern for healthcare delivery. One interesting aspect is also the food and hygiene part, not just the medical care, not just that, because health, we approach it from a wellness angle, and it encompasses everything from from our nutrition to our activity, to being fit, and to be mentally sound and things. So health and hygienic food street is one new component, one new scheme that we have incorporated in our urban health mission, national urban health mission scheme. And already 100 healthy and hygienic food streets, as we call them, are sanctioned to hundreds of districts across the country. The states select these, and they are to develop these locations into with standards prescribed for offering healthy and hygienic food to the people in that locality. And 1 crore is given as an initial start to all these for the food streets in the different location. Another area where we could have engagement, collaboration is in community engagement. In the rural areas, we typically have the panchayats, we have the self-help groups, and then we have village and health and nutrition committees. And there's a lot of otherwise community involvement. In the urban areas too, we need to push this angle further, community engagement, because more often people are coming from different places, coming together in one, and there may not be the traditional sense of community feeling, maybe like we may find in the villages. But this is an area where in urban areas too, through collaboration, the urban local bodies are working with the local population which are there, and the healthcare facility workers and all the support staff can also come in here, and we can bring in better community management. And last but not the least, another area is for overall, like I said, overall health and wellness improvement, that we can we look at areas where we are talking about health-seeking behaviors, and can we have areas of collaboration where, say, open air gyms, parks, and cycle tracks, sports facilities, urban areas, because this physical activity being an important component of overall health and wellness, this is an area where we can definitely work and do. I'm sure it will result in much better health outcomes for the people in the urban areas. Smart cities and use of technology, both the ministries are heavily using a lot of technology in their development schemes. And can we bring in a lot of focus in this area when we use digital technology and when we're talking about smart cities? Let us keep the health aspect at a place of prominence through collaboration in the National Urban Health Mission and with schemes of the Ministry of Health, of Housing and Urban Affairs. So with this, I would just wanted to try to bring in some context setting for today's deliberations. I thank you for once again for coming to attend this conclave. I extend a warm welcome to the dignitaries and to all the delegates present here. And I wish for a very good, successful deliberation today. Thank you very much. Jai Hind.
Thank you, ma'am, for the inaugural address. Now I would like to invite Ms. Veena Reddy, Mission Director, USAID, to share insights on investment in urban health as the need of the hour.
Namaskar. It's truly a pleasure and honor to be here today with all of you at this exciting event. Thank you to the Ms. Chung-san for those very educational and interesting remarks, including a really wonderful overview of the amazing work that you all are doing. And it really gives me immense pleasure to be part of this national level deliberation for how we're strengthening the urban healthcare system. And I thank and congratulate the Ministry of Health and Family Welfare and the Ministry of Housing and Urban Affairs for organizing this important initiative. So I work at the U.S. Agency for International Development, part of the U.S. government, and we really believe that a strong primary healthcare system will pave the way for countries around the world to build healthy families, stable communities, and productive economies, as well as promoting self-reliance. And we've seen this promise in the leadership we've seen in India. We've seen it in our decades of collaboration. We've seen it at the G20, and not just with the government, but with civil society, with leading organizations like the Gates Foundation and PATH that we're really proud to collaborate with. And we all see together that the world is really changing. The McKinsey Global Institute estimates that by 2030, there will be 68 Indian cities of more than 1 million people, 13 with more than 4 million, and 6 megacities with populations of 10 million or more. And as we heard, the National Urban Mission focuses on of cities of more than 50,000. So imagine all of these will be growing as India's population grows and these demographic shifts take place. But cities can offer wonderful benefits, jobs, increased services, and culture. But without adequate planning, these resources will be stretched thin. Like all resources, the most harmed will be those that are already marginalized or vulnerable. And USAID has had a long history of working with the government of India to advance urban healthcare services. And we're really proud to have been at the beginning of some of these discussions as a development partner. And this work really has transitioned over time. We worked with the Indian government as they created some of the urban health systems, and now that are being operationalized, becoming more inclusive, more resilient, and can offer lessons for the world. Some of the newer examples of our work include a partnership with Hak Darshak, a social enterprise, where USAID worked to facilitate access to social security benefits for citizens. As a result, more than 60,000 urban poor, especially women, girls, and persons with disabilities, were able to access social security benefits. And in collaboration with the government of Karnataka, USAID pioneered sewage surveillance in Bengaluru to track and manage COVID-19 clusters, detecting COVID-19 pathogens. And this data has informed local municipalities towards action in addressing the pandemic. Our Asian Resilient Cities activities is working in Rajkot, Gujarat, to address cross-cutting urban development challenges by supporting resilient, low-carbon urban infrastructure and integrating climate change and environmental considerations into urban approaches. And with respect to the healthcare needs of women, children, and adolescents, USAID helped craft operational guidelines to integrate reproductive, maternal, newborn child, and adolescent health services at urban primary healthcare facilities, helping to connect all the members of community to primary health services. And we're also working on a project to catalyze innovative health financing models and provide support to social enterprises for improving access to affordable and quality healthcare for over 10 million urban poor. Through this activity, USAID is also helping reduce the out-of-pocket healthcare expenditures for the urban poor by 30%. And finally, we're also working with the government of India on the national flagship urban water and sanitation programs, along with the Ministry of Housing and Urban Welfare, to foster healthier urban communities and improve livelihoods by increasing access to safe water and sanitation, improving public sanitation services, training professionals on septic management, and increasing access to safe water and sanitation services. These are just some examples of what we've been able to achieve together in India. And we've also shared successes. These successes also have lessons for the world. And the way we look at our partnership in India is partnering with India on global development challenges, some of which also do need to be addressed in India, but will provide lessons for the world. So in this respect, we started a city-to-city COVID-19 vaccination learning exchange program, where it facilitated knowledge exchange among 15 cities in Asia and Africa, including 9 in India. The cities shared insights, best practices, and challenges concerning COVID-19 immunization in real time as we were all addressing the pandemic in our own communities. So we really believe that by working together on the intersection of primary care, climate, and One Health, we can make a huge difference, not just for India, but for the world. And this proven track record of working with across stakeholders, government, private sector, NGO, other donors, other development partners has been proven to be very effective. And we think we can take this agenda of looking at urban healthcare to the world. And we really recognize that convergence is one of the great challenges of all governments, including our own, but it's key to solving these complex issues like climate change or global health security. We need to look at things holistically, and I'm really pleased at the recent presentation that we saw of how much the government is looking at the intersection of all of these different factors. And so these two ministries coming together is really a wonderful demonstration to the rest of the world of how we can bring a holistic lens to some of these huge challenges. So we're privileged to build on our longstanding partnership in urban health with the government of India to help others learn and build upon successes in urban healthcare. We look forward to continuing to coordinate across the health sector, as well as other sectors such as education, water sanitation, hygiene, and mobilize a whole of society effort that includes public and private sectors and communities in health efforts, because what we do in India will help the world. Thank you so much.
Thank you, ma'am. May I now please invite Shri Sudhansh Pant, Secretary Health, to share his views on why urban health is not just about health.
Namaskar. Maanniya Manoj Joshi ji, Sachiv, Ministry of Housing and Urban Affairs, Government of India. Adarniya Madam Ramchangoi Sweetie Chanson, Additional Secretary, Ministry of Health. Adarniya Dr. Veena Reddy, USAID se. Adarniya General Kotwal, NHSRC से, आदरणीय विशाल चौहान जी हमारे संयुक्त सचिव मंत्रालय में, यहाँ उपस्थित समस्त राज्यों के स्वास्थ्य विभागों के वरिष्ठ अधिकारीगण, अतिरिक्त मुख्य सचिवगण, प्रमुख शासन सचिव, सचिव, मिशन डायरेक्टर्स, कमिश्नर साहिबान और अन्य वरिष्ठ अधिकारी, इसी तरह अर्बन लोकल बॉडीज डिपार्टमेंट्स के सेक्रेटरीज, प्रिंसिपल सेक्रेटरीज, एडिशनल चीफ सेक्रेटरीज, डायरेक्टर्स, दूसरे सीनियर ऑफिसर्स, यहाँ विभिन्न संस्थाओं से पधारे समस्त सम्मानीय अतिथिगण, मीडिया के सम्मानीय प्रतिनिधिगण, स्वास्थ्य मंत्रालय एवं अर्बन मिनिस्ट्री के समस्त वरिष्ठ अधिकारीगण, देवियों और सज्जनों, आज एक प्रसन्नता का दिन है, क्योंकि जब भी स्वास्थ्य के बारे में चर्चा होती है आमतौर पे हमारा फोकस ग्रामीण क्षेत्रों में स्वास्थ्य सुविधाओं पर रहता है। ग्रामीण क्षेत्रों की समस्याएं भिन्न हैं, वहाँ एक्सेसिबिलिटी की, अवेलेबिलिटी ऑफ हेल्थ सर्विसेज, ये इश्यूज रहते हैं। शहरी क्षेत्र जहाँ धीरे धीरे हमारी करीब 1/3 आबादी अब शहरी क्षेत्रों में बस रही है, धीरे धीरे ये प्रतिशत और बढ़ रहा है। शहरी क्षेत्रों में स्वास्थ्य सुविधाएं निश्चित तौर पे ग्रामीण क्षेत्रों से बेटर हैं, लेकिन वहाँ दूसरी तरह की समस्याएं हैं। आज प्राइमरी उपचार के लिए किसी को जाना पड़े तो वो टर्शरी केयर हॉस्पिटल में जाता है। एम्स न्यू दिल्ली, नई दिल्ली का जो एम्स है, वहाँ 50% जो आउटडोर है वो ऐसे पेशेंट्स हैं जो प्राइमरी लेवल के हैं, मामूली खांसी, जुकाम, दर्द। तो उससे क्या होता है, टर्शरी फैसिलिटीज चोक हो जाती हैं। आज एम्स का एवरेज ओपीडी 12 से 15 हज़ार पेशेंट्स पर डे, उसमें 5 से 6 हज़ार ऐसे हैं जो किसी अर्बन पीएचसी में, अर्बन हेल्थ एंड वेलनेस सेंटर में एक बुखार की, खांसी की, गले खराब की दवाई ले सकते हैं, लेकिन किसी कारण से वहाँ आते हैं। तो आवश्यकता क्या है, अर्बन एरियाज में हमें अपना प्राइमरी हेल्थ केयर और सेकेंडरी हेल्थ केयर नेटवर्क को और मजबूत करना है। नेशनल अर्बन हेल्थ मिशन के बारे में मैडम चांगसन ने बताया, बहुत सालों से चल रहा है, बहुत उसमें हेल्थ एंड वेलनेस सेंटर बने अर्बन में, बहुत अर्बन पीएचसी, सीएचसी बने, और लेकिन उनकी विजिबिलिटी उतनी है नहीं। लोग बड़े अस्पताल में जाना पसंद करते हैं। वो क्रेडिबिलिटी जो आज एक प्राइमरी और सेकेंडरी हेल्थ सर्विस फैसिलिटी अर्बन एरियाज में जिसकी होनी चाहिए, वो आज उतनी नहीं हो पाई। कुछ स्टेट्स, जैसा दिखाया गया, 3 कैटेगरीज हैं। कुछ स्टेट्स जैसे महाराष्ट्र, गुजरात, वहाँ अर्बन लोकल बॉडीज इतनी स्ट्रांग है, उन्होंने आगे आके अर्बन हेल्थ का जिम्मा पूरा अपने ऊपर लिया है। मुंबई म्युनिसिपल कॉर्पोरेशन तो मेडिकल कॉलेजेस भी खुद के चलाता है। गुजरात में बहुत से म्युनिसिपल कॉर्पोरेशन हैं, पूरी तरह से हेल्थ केयर वही सपोर्ट कर रहे हैं। स्टेट गवर्नमेंट हैज टेकन अ बैक सीट। तो इसलिए, लेकिन अधिकांश राज्य ऐसे हैं जहां अभी भी अर्बन लोकल बॉडीज, म्युनिसिपल कॉर्पोरेशन, म्युनिसिपैलिटीज, म्युनिसिपल काउंसिल्स, वो अभी हेल्थ में उतना इन्वॉल्व नहीं हुए हैं। और जब तक अर्बन लोकल बॉडीज हेल्थ को अपनी प्रायोरिटी में नहीं लेंगे, जैसे इलेक्ट्रिसिटी सप्लाई, वाटर सप्लाई, सैनिटेशन सर्विसेज प्रायोरिटी पर रहती है, हेल्थ सर्विसेज प्रायोरिटी में लेंगे, तभी अर्बन हेल्थ सर्विसेज ज़्यादा उनमें सुधार आएगा। स्टेट गवर्नमेंट के पास इतना बड़ा मैंडेट है, एक एक गांव तक उसको पहुंचना है, एक एक छोटे शहर, कस्बे, बड़े शहर, सब में फैसिलिटीज करनी है। समहाउ अर्बन हेल्थ प्राइमरी और सेकेंडरी लेवल पे थोड़ा नेग्लेक्ट हो जाता है एज कंपेयर टू रूरल हेल्थ। तो इसलिए बहुत आवश्यक है, इसीलिए आज प्रयास किए गए कि अर्बन हेल्थ पे चर्चा है। माननीय जोशी साहब हमारे समक्ष आए हैं, सेक्रेटरी हैं अर्बन के, और उनकी प्रेजेंस से ही मात्र यहाँ पर एक बहुत बड़ा सपोर्ट मिलता है कि अर्बन लोकल बॉडीज का जो नेटवर्क है वो यदि ये जिम्मेदारी समझ के और जो कहते हैं रिस्पॉन्सिबिलिटीज, रोल्स, डेवोल्यूशन ऑफ पावर्स, वो सब हो चुका है कॉन्स्टिट्यूशनल अमेंडमेंट के बाद। पब्लिक हेल्थ इज विद इन द डोमेन ऑफ अर्बन लोकल बॉडीज, लाइक इन रूरल एरियाज इट इज अंडर द डोमेन ऑफ द ग्राम पंचायत। लेकिन अर्बन बॉडीज किसी कारण आगे नहीं आ रही हैं, उनके फाइनेंशियल इश्यूज हैं, जो भी है। मोस्ट अर्बन लोकल बॉडीज में आज हेल्थ एंड सैनिटेशन के नाम पे सिर्फ सैनिटेशन, स्वीपिंग, क्लीनिंग और वो सभी चीजें होती हैं। अगर एक हेल्थ ऑफिसर, एक डॉक्टर होते भी हैं, वो सुपरवाइज करते हैं क्लीनिंग का, सैनिटेशन का, सीवरेज नेटवर्क का। ठीक है, दैट इज ऑल्सो an important part of health, because if you have clean cities, good sewerage systems, STPs, etc., then it also impacts public health. But directly into primary and secondary health care, urban bodies still have a long way to go. So this is the forum where I would also like to urge and request all the representatives of the urban bodies who are here, all the representatives of the departments of the local self-government, etc., who may be here, that kindly start taking more interest in the health facilities of the urban areas, because even if financial constraints are there, see, ultimately the state government is in a way funding the urban health facilities. The same money could come through the municipal bodies. In any case, whether money comes directly from the state government through the health departments for these urban facilities, or it comes from the state government through the local self-government departments and then to the municipalities, it is the same thing. State government is going to spend the same if the local bodies are not financially sustainable themselves. But if the urban bodies take the ownership of the health facilities in the cities, our primary and secondary health care services will greatly improve over their present levels. Some of the cities have utilized these services and rebranded them. Like in Delhi, they made them Mohalla Clinic. In Punjab, they made them something else. Maharashtra is also trying to make it something else. But let me make it very clear, if the states start giving their own brand names to the primary and secondary healthcare facility in the urban areas, then we would be constrained and we would not be able to support them financially under the National Health Mission. So all these states who have stopped using the common nomenclature of health and wellness centers, PHC, CHC, etc., unfortunately, the funding has not been very forthcoming. So when we run a national program, we expect that all states and union territories have to follow the common branding. तो इसलिए ये भी आवश्यक है कि हमारे जो भी राज्य सरकारें हैं वो न सिर्फ अपने अर्बन बॉडीज को मजबूत करें ताकि स्वास्थ्य सेवाएं वो अपने दायरे में ले सकें अन्य सेवाओं की तरह, बल्कि और उसकी फंडिंग वगैरह में भी सपोर्ट करें। केंद्र से भी जो फंड्स की आवश्यकता होगी, कोई कमी नहीं है फंड्स की। NUHM का बहुत बड़ा बजट है, हर साल बहुत सपोर्ट होता है। इसी तरह एक नई योजना आई है, प्रधानमंत्री आयुष्मान भारत हेल्थ इंफ्रास्ट्रक्चर मिशन, PMA भीम, 65,000 crore rupees just for infrastructure creation over 4 years. बहुत से काम शहरी क्षेत्रों में हो रहे हैं। कितने काम स्वास्थ्य विभाग के माध्यम से हो रहे हैं, कितने अर्बन बॉडीज के माध्यम से हो रहे हैं, वो आंकड़ा है, लेकिन उसमें हम जाएंगे नहीं अभी। लेकिन उसमें भी शहरी निकायों की भागीदारी बहुत कम है। हमारी ये सोच है कि यदि शहरी निकाय स्वयं अपने शहरों में स्थापित होने वाली स्वास्थ्य सुविधाओं की ओनरशिप लें, यदि उसके सुविधाओं के विकसित होने से लेकर उनके पूर्ण होने तक उसमें इन्वॉल्व रहें, वहां पर अपने स्टाफ को पोस्टिंग करें, स्टेट गवर्नमेंट से डेप्यूटेशन, अगर खुद नहीं है तो डेप्यूटेशन पे लेके उनकी पोस्टिंग करें, यदि उनका सीधा उस पर कंट्रोल रहेगा तो निश्चित रूप से सुविधाएं और बेटर होंगी। अर्बन लोकल बॉडीज हमारे यहाँ इलेक्टेड बॉडीज हैं, वहाँ आपके हर वार्ड में एक रिप्रेजेंटेटिव होंगे, पार्षद होंगे, मेयर होंगे, हेड ऑफ द म्युनिसिपल काउंसिल होंगे, जो भी हैं, जिस भी डेजिग्नेशन से उनको कहें। तो पब्लिक रिप्रेजेंटेटिव होने के नाते भी सर्विसेज में इम्प्रूवमेंट आएगा, क्योंकि कोई ना कोई उनको देख रहा है। स्टेट गवर्नमेंट में हजारों PHCs में, हजारों CHCs में सिर्फ सरकारी अधिकारी की देखरेख में होगा, शायद उतना फोकस उन पे नहीं हो पाएगा। तो कई तरह के इसमें इश्यूज हैं। हेल्थ हम सबके लिए बहुत आवश्यक है, चाहे शहरी क्षेत्र का व्यक्ति हो, चाहे ग्रामीण क्षेत्र के व्यक्ति हो। शहर में लोगों की एक्सपेक्टेशंस भी ज़्यादा हैं, थोड़ा पेशेंस भी कम है, और डिमांड्स बहुत ज़्यादा हैं, लोग जागरूक ज़्यादा हैं, और जो उनके प्रेशर रहता है हेल्थ फैसिलिटीज़ पे बहुत ज़्यादा रहता है। तो अगर हम टॉप मेट्रो सिटीज़ को छोड़ दें, तो सेकेंड टियर, थर्ड टियर के जो शहर हैं, उसमें भी आज स्वास्थ्य सेवाएं बहुत तेज़ी से विकसित हो रही हैं। मेरा ये मानना है कि सरकारी सेवाएं एक पहलू है, प्राइवेट हेल्थ सर्विसेज वो एक पैरेलल हमारा बहुत मजबूत पिलर है। हम ये नहीं कहते कहीं पर कि सरकारी सब हेल्थ फैसिलिटीज देगी, प्राइवेट सेक्टर भी मजबूती से साथ में खड़ा हुआ है, उसके लिए भी फैसिलिटेशन बहुत ज़रूरी है। सरकारी संस्था में हम लोकल बॉडी में काम करते हैं, चाहे वहाँ के चीफ एग्जीक्यूटिव हों, चाहे कमिश्नर हों, चाहे डायरेक्टर हों, चाहे जो भी एग्जीक्यूटिव ऑफिसर हों उस म्यूनिसिपैलिटी के, जो भी डेजिग्नेशन हो, अगर कोई प्राइवेट हेल्थ फैसिलिटी सेटअप करने के लिए भी उसको कोई फैसिलिटेशन चाहिए इन टर्म्स ऑफ allotment of land, in terms of land use change, in terms of passing of building plans, whatever it may be, उसमें भी हमें फैसिलिटेट करना है। ये नहीं सोचना है कि ये तो बिजनेस करेगा, पैसा कमाएगा। अब कोई प्राइवेट अगर संस्था सेटअप करेगा तो नेचुरली वो चैरिटी के लिए तो नहीं करेगा, थोड़ा बहुत तो पैसे भी कमाएगा। दिस इज समथिंग विच वी विल हैव टू एक्सेप्ट, बट स्टिल वी मस्ट फैसिलिटेट, बिकॉज ही इज डूइंग इट टू स्ट्रेंथन the health services of this country, of that city, of that state. तो उसके प्रति भी आपका एटीट्यूड ऐसा होना चाहिए कि सपोर्टिव और फैसिलिटेटिंग एटीट्यूड होना चाहिए। ये नहीं सोचें कि ये तो प्राइवेट वाला है तो इसको परेशान करें। तो ये भी आप लोग ध्यान रखिए, जिस पोजीशन पे हैं, हेल्थ सर्विसेज यदि विकसित होती हैं, सरकारी क्षेत्र में होती हैं तो बहुत अच्छा है, लेकिन सरकार के अपने कॉन्स्ट्रेंट्स हैं, वो अनंत नहीं कर सकते हैं। और निजी क्षेत्र में होते हैं तो डेफिनेटली निजी क्षेत्र वाला सेवाएं भी देगा, लेकिन थोड़ा अपने लाभ के बारे में भी सोचेगा। वो ठीक है, हमारे सिस्टम में दोनों चीजें साथ साथ चल रही हैं, उसको भी हमें एनकरेज करना है, उसको जो है वो स्कटल नहीं करना है। ये भावना भी आप अपने मन में रखिए। तो इसलिए आज दिन भर की ये वर्कशॉप है। मैं आशा करता हूं कि आप एक्सपर्ट्स यहाँ पर आए हैं, आपके विचारों से हमारे विभाग लाभान्वित होंगे, और शहरी क्षेत्रों में जो स्वास्थ्य की नीतियां बनेंगी या जो स्वास्थ्य का इंफ्रास्ट्रक्चर बनेगा, उसमें आपके विचारों को हम इनकॉर्पोरेट करेंगे, ताकि हमारी नीतियां और ज़्यादा सुचारू रूप से बन सकें और ज़्यादा प्रैक्टिकल हों, जिनका क्रियान्विति इम्प्लीमेंटेशन हमारे लिए आसान रहे। और मैं आशा करता हूं कि आज की वर्कशॉप सफल रहेगी। मंच पे जो महानुभाव विराजमान हैं, उनका मैं आभार प्रकट करना चाहता हूं। आप सभी ने अपने बहुमूल्य समय में से कुछ समय इस कॉज के लिए आज यहाँ पर दिया। आप सभी को बहुत बहुत धन्यवाद। जय हिंद।
Thank you, sir, for sharing your valuable insights with us today. May I now invite Shri Manoj Joshi, sir, Secretary, Housing and Urban Affairs, who will address the gathering on opportunities for collaboration between Ministry of Health and Family Welfare and Ministry of Housing and Urban Affairs.
Good morning, Mr. Sudhanshu Pant, AS and JS from Health Ministry, Dr. Veena Reddy, General Kotwal, friends. Very happy to participate in this discussion on urban health. I think you must have heard umpteen times how large India's urban population is growing. We take, take 31% as India's urban population as per last census. It's about 35-36%, but various estimates suggest it's about 50% of India's population at present. If we count large number of census towns, there are about 5,000 census towns in India which have a population of above 50,000, which are not considered as urban local bodies. And then there are about 4,900 urban local bodies. So put together, it's a pretty large population. And the focus in urban areas for urban local bodies has always been infrastructure and sanitation. Health, both for state government, central government, and urban local bodies in urban areas is not really been area of priority. It's largely the district hospitals or medical colleges or CHCs in urban areas which take care of urban health, or the private sector. Last few years, we have started small efforts in urban health mission. There are still small efforts, but very good that now Government of India is spending large amounts or proposing to spend large amounts in urban areas. The requirements, the urban areas don't fulfill only the urban area requirements, they fulfill the areas all around them. Another 100-200 kilometers is the hinterland, which also these urban centers serve. But primary care, as Health Secretary said, is an area which is, except for the old towns, say Bombay State, that is Gujarat, Maharashtra, Delhi, and a few areas here and there, Calcutta, which have worked on, local bodies have worked on urban health. But rest of the country, yes, other than large hospital, it has been neglected areas. So when we are starting these urban wellness centers and health centers, it's a very good initiative. But we have to also understand that reach and funding of government in India is limited. And we have to make the most effective utilization of that funding. Should we adopt whatever we are doing in the rural areas? Or do we ask people what do they want? Not just the health department, which makes the policy, but people for whom policies or infrastructure is being made. Are we really consulting them? We must be consulting in the states and center, but I'm not very sure whether that consultation is resulting in the most cost-effective investment in health. I saw the presentation by AS on the staffing which we are thinking of urban areas. Is that the ideal staffing for urban areas? I don't know. I have worked in health department earlier, but probably the requirements do change. The same network of ASHAs and all, whether that is the most effective means in urban areas, we probably need to debate these points, which is the most cost-effective intervention in urban areas. In general, we make PHCs or wellness centers based on the population or area distribution. Is that the most effective distribution in urban areas, or do we focus more on the areas where poor people live? Or so in our normal middle class areas, what is the requirement? Is that different from what is the requirement in a slum or an unauthorized colony? Are the same requirements, same structure in urban wellness center do we require? I'm not sure. Probably we need to debate that. Within the urban areas, there are people with different income strata, different access to health. Do we probably some of the people would require a different treatment. when you go to slums and different areas, yes, there is a problem of finding space to open the health center or a wellness center. So that is a role where urban local bodies have to play a lot of role along with the state government in funding that infrastructure and finding the space. But probably the states where traditionally urban local bodies are not doing healthcare, probably the health department is in a best position to man them. It's not easy to build capacity to and SOPs to run a system of healthcare with the doctors and with systems. So a collaborative approach in infrastructure being funded in a way through urban local bodies, and the manning and running of the operations could be by the health department in the areas where ULBs have not been active in health sector. How much of outreach we do in terms of immunization and other activities in urban areas? Yes, urban areas have a large poor migrant population where we miss out immunization, and which is the most cost-effective way to reach out to them. There are poor areas where probably we miss out them most. There is no enumeration of who are the people living there. It's a changing urban migrant population. No one really knows who all are living there. Their Aadhaar cards or citizenship card or voters ID cards are of the rural area. Their ration card is of the rural area. Half the family is with them in the urban area, half the family is in rural area, so they don't have access to ration card. They don't have they are not a voter there. Over a period of time, they do become voters there, but in the beginning, 5-10 years, when they are most vulnerable, they don't have any access to government service. They just buy some or rent out some place in the poor areas and live there. So they are probably in the most need for health services, immunization services. So probably we need a focus on a different target populations in the city. Whether that type of flexibility, how do we build it into the system? We will need to think about that. Urban local bodies are generally very starved of funds. They have all types of priorities, except for, say, some urban local bodies who have large bank deposits like Bombay Municipal Corporation. Most of the other urban local bodies, even if they have a 10,000 crore budget, they're just hand to mouth. Even say, so there are very few, probably 5-7 urban local bodies who are quite cash rich, probably Mumbai, probably Pimpri Chinchwad, even a rich municipality like Pune, with very large population, a very prosperous population, still their budget goes into deficit because the infrastructure requirements, water, sanitation requirements are very large. So for them to spend funding on healthcare would be a challenge. And then it's a question of responsibility. They don't believe that people are expecting them to do that. People are expecting probably the state government to take care of healthcare facilities. So why should they get into another area when they are so short of funds? Why should they get into another area and take headache for that? So if we provide them funding, they would get involved. So state governments are providing fundings. So in a way, it has to be they have to be goaded gradually into getting into a healthcare, because as Health Secretary said, without local involvement, the accountability of health system would not be there. So I have worked in Kerala at various levels, also in health department also. So I've seen the accountability, which now what we call as Rogi Kalyan Samiti, earlier you used to call them hospital development societies. A lot of accountability they bring in. They enable hospital to start charging from people. The state governments are generally very reluctant to charge for any facility. Rogi Kalyan Samitis are far more keen to charge people and provide facilities. So if you go out for tests, if it's costing you 200 rupees, if by charging 20 rupees, if the hospital can provide the same tests, Rogi Kalyan Samitis are far more willing to do that. So urban local bodies would be far more willing. People who are closer to people, so the elected system which is closer to people is far more willing to pay. Sometimes people who are farther are less willing to pay less willing to charge for the facilities. So involving urban local bodies and different structures at ward level and below is a very effective way to bring accountability, as well as to resolve local problems, to get land for starting health facilities is a very, very effective way. But they don't have funds. So funding has to come from center or state government. So that type of collaboration, I see a very, very effective way of extending urban services. But again, as I would emphasize on the issue of cost effectiveness in health services. We have extended our health services both in urban and rural areas in large ways. And the Government of India and state governments are ever expanding their budgets in health sector. But we are not always very cost effective. We need to take care of that. Sometimes it's one reason why government health system is considered the right way to approach people in India is because it is cost effective. A small facility caters to a very large number of people. So per patient, per operation, per test, cost comes very low. In few super specialty large private hospitals, the cost for each activity comes very, very high. I'm not talking about the charges, I'm talking about the costs. While at the same time, there are facilities in private sector, say some of the testing labs, even in Delhi and the other places, they're very, very efficient, provide facilities at very low cost. Few hospitals in India are more like a factory setup, provide facilities and operations at very low cost. So costing in the Indian context of healthcare facility is very, very important. So what type of collaboration we require in urban area between private sector and government, where we involve the efficient private sector, not low cost, inefficient private sector, but high quality, low cost, efficient private sector, say in testing. It's not easy to set up all these facilities in government level. So probably a collaboration of that kind could be very effective. Probably a collaboration of in immunization and other facilities with urban local body could be very effective, with the doctors and core facilities coming from the health services side. So collaboration and cost effectiveness are the two areas I would consider as a very, very important in urban health sector. And third is identifying what level of, what strata of people require what type of services in urban area. I think that these are the three points I consider with whatever understanding I have in health system as well as in urban areas. I would like to put before you for a discussion and deliberation, so that urban poor, where they don't get a lot of facilities, water supply, they're still getting now. Sanitation has improved a lot. Sewage system has improved, a lot to go. Infrastructure improvements are happening, but healthcare is primarily private sector for poor in urban India. So we are changing that, and that's a great thing. And we need to do it very fast. Because that's what decides a poverty and extreme poverty for people in India. A healthcare problem, because going to hospital is so difficult, whether private probably is faster. Going to say RML or AIMS wastes a full day, and that would be about 500 rupees for them. So to waste a full day just to consult a doctor is a very, very inefficient way. If they can do it in half an hour or 1 hour someplace nearby, even if they have to pay some money, probably is a much better productive utilization of country's resources. So we need to consider what different stratas of people in the cities require and dovetail our systems according to that. Thank you for inviting me and have a good discussion. Thank you.
Thank you, sir. Now I will invite Shri Vishal Chauhan, sir, Joint Secretary Policy from Ministry of Health and Family Welfare, to please deliver the vote of thanks.
And thank you very much, sirs. Today we had a very fantastic inaugural session, and we are very pleased that Honorable Secretary, Government of India Urban Affairs, Sri Manoj Joshi sir is with us. Sir has given us a unique opportunity to rethink the whole urban framework concept. So today we will be releasing a draft National Urban Health Mission Framework 2023. The last one was released in the year 2013. And sir, we are very sure that issues raised by you will give us an opportunity to rethink. And once it is in public domain, we hope to expect much more suggestions, both from health departments, urban municipal bodies, and also the urban health department, urban bodies of the or urban departments of the state governments and national governments. So, sir, it is as you said, sir, the challenges before in the urban areas are very, very unique. There are migratory populations. There are the burden of non-communicable diseases like hypertension, diabetes, or the COPDs, chronic obstructive pulmonary diseases. There are issues of pollution. There are challenges of land spaces, and the lack of the infrastructure or a lack of a framework are before us. But fortunately, there are some advantages also there. In urban areas, there is ample opportunity for the public-private partnership. There are also ample opportunities. The funding is not an issue. We get, and it's a godsend opportunity that under 15th Finance Commission, we have got about 70,000 crore for the our rural and urban local bodies, in which 26,000 crore is going for the urban local bodies. Under the PMAVIM also, a lot of fund is provided. Under National Urban Health Mission, is lot of fund is provided. And also, fund is not always the requirement, because we have many cash-rich urban local bodies. So probably what they need is a structure. What they need is a framework to implement the health schemes, as we have been doing in the rural areas. So, sir, we are very thankful for your guidance on the whole issue, sir. And today we have three thematic sessions are there. So the first session will be on very much on this topic, that how to make a framework, how to make a structure in the urban local bodies. We are also discussing with Bombay Municipal Corporation, who said that we don't have shortage of fund, but what we need a structure, how we can have some director public health, how we can have director public health services or health services which can run hospitals and medical colleges, how we can have some program officers who can take care of the NCDs, who can take care of the mental health, who can take care of the immunization programs. So probably we have to replicate something, but in a different way, as the urban health scenarios is there. We are very, very thankful to Sudhansh Pant sir also for giving his valuable time and putting all the things in perspective. The issue raised by Secretary sir is that if we are able to manage our 80% of the cases at the primary health center, the overcrowding at the secondary and tertiary hospitals will be much less. And we are aware that the principle applies both in the urban and rural areas, that 80% of the issues can be held at the primary healthcare level. So we have to build a network of the primary health centers in the urban areas also. We call it health and wellness centers. And these are at a population of about 50,000 or so. And also there is a medical officer posted there. So that's a big difference as compared to the rural areas. In rural areas, we have a trained nurse. And also, sir raised a very important point, that it is not only for the poor actually. In fact, one of my professor used to say, if we design services for the poor, they become poor services. So we also have to take care that the urban middle class, the urban lower middle class should feel comfortable to visit those facilities. And especially the elderly population, those who cannot travel that much far or those who are alone, they should be find a clinic in the neighborhood and use these facilities. So we have to design our facilities which not only caters to the slums, which also caters to the flat population or those living in the better off areas. Sir, thank you very much for giving this perspective, sir. I am also very thankful to our additional secretary and mission director, madam, for giving doing the context setting and giving a whole perspective and setting the tone for this conclave. And we are very helpful that in the coming 3 sessions, we are going to have very fruitful discussion. I am also very thankful to Dr. Veena Reddy, mission director of the USAID, for coming here, sharing her thoughts, and also providing support, technical support and other kind of support for this conclave and in our other programs. I'm very thankful to Dr. Atul Kotwal, also Executive Director NHSRC, who has always been providing us the technical support. And the urban framework, which today draft framework, which today will be releasing after some time, a lot of contribution has come from our urban health division, our partners, and NHSRC. So we are very thankful to the Dr. Kotwal and his entire team. We are also thankful that senior principal secretaries, ACS Health, ACS Urban Development, municipal commissioners who have come from far off places to attend this conclave. And I'm very, very sure that their valuable inputs will be very, very useful. And we, in a month or so, based on the input given, we'll be able to come out with a final our national urban health mission framework. And also, I'm thankful to all the partners, all the BMGF, PATH, and other agencies who have been supporting us in this initiative. And I'm very, very hopeful that after this day-long deliberations, we'll have a very fantastic document, and which will make a road for our urban health, will make life of the urban citizens much easier, as we always talk about ease of living for the citizens. Thank you very much, sir.
Thank you, sir. We will now be presenting mementos to our dignitaries. Can I please invite Neeraj Jain, Country Director, PATH, and Dr. Anuradha Jain, Senior Advisor, Health System Strengthening, USAID. Can I please request Neeraj to present the memento to Shri Manoj Joshi, sir, Secretary, MoA. Can I also request Neeraj to please present the memento to Shri Sudhansh Pant, sir, Secretary, Health. Please provide the memento to Ms. L.S. Changsan, ASNMD. Shri Vishal Chauhan, Joint Secretary, Policy. Major General Atul Kotwal, sir, Executive Director, NHSRC. Ms. Veena Reddy, MD, USAID. Can I please request our dignitaries to stay on the stage so that we can commemorate this moment with a picture, it's a group picture. We will now be breaking for tea and coffee. Please join us at 11 a.m. sharp for our first panel discussion. Thank you. Please join us for tea at the left area, the zone that is at the left of the conference hall. Thank you.